Hi, I'm John Kane. On behalf of CME Outfitters, I'd like to thank you for participating in BriefCase 2 of the four-part CMEO BriefCase series called Treatment Hurdles in Schizophrenia and Bipolar Disorder, applying real-world cases to overcome challenges in real-world management. This edition of the CMEO BriefCase is titled Best Practices for Incorporating LAIs into Treatment Planning for Schizophrenia. The goal of this activity is to identify patients with schizophrenia who are ideal candidates for long-acting injectable therapies and strategies for transitioning from oral therapies. We are using a unique platform today that is designed to not only provide you with key strategies to improve the management of schizophrenia, but opportunities to reflect and dive deeper into those strategies. As you progress through the BriefCase, you will see key points of emphasis along with relevant resources and tools appearing at the bottom of the screen. You may choose to take your own notes by clicking the Add Note button at the bottom right and access those notes on Activity Review page at the conclusion of the BriefCase. You can also access a robust resource library, including articles, guidelines, and practice tools by clicking on the book icon also at the bottom right. So let's begin with our patient, James, a 20-year-old white male student previously hospitalized with schizophrenia and discharged on an oral antipsychotic. After 5 months of psychotherapy and pharmacotherapy, James returned to college after taking a leave of absence. Shortly after returning to school, he stopped taking his medication. Within 4 months of discontinuing his medication, James relapsed, characterized by paranoid delusions and a thought disorder. James was hospitalized and again treated with an oral antipsychotic. His response was not as rapid as it had been during his first episode, but he did achieve relative remission and is discharged. Hi, James. It's good to see you again. How are you doing?
Hi, Dr. Kane. I'm okay, I guess. I'm just really glad to be out of the hospital. I really don't want to have to go back.
Yes, I'm glad that you're out of the hospital, but sorry that you had a relapse. And how are you doing now? Have you been having any other thoughts about your professor, Dr. Stein?
No, not really.
The last time that we saw one another, we discussed a relapse prevention plan with your taking your pills every day as prescribed. I guess that you had a hard time with that.
Yeah, well, they said that because I stopped taking my medication, I had a relapse, and that's why I had to go back to the hospital. Honestly, Dr. Kane, I don't want to relapse again. I don't want to have to go to the hospital again and again and again. I'm 20 years old. I want to live my life.
So why did you stop taking your medication? And were you experiencing side effects?
No, sometimes I still forget to take them. And other times, well, I just want to forget about the whole thing. I mean, I every time I take the pills, I remember. I mean, my mom calls me, "Did you take your pills?" My dad calls me, "Did you take your pills?" I mean, I feel like I'm talking about taking pills more than anything else in my life.
Okay, I understand, but let's talk more about convenient ways that you can get your medicine. So since you didn't have any annoying side effects from the pill version of the medicine, we can try a long-acting formulation of the same drug. You'll still have the benefit of the medicine, but you don't need to remember to take pills every day. The medicine's given by injection just once a month. And with a stable amount of medicine in your system, your risk of relapse and rehospitalization should be significantly reduced. And that can enable you to go back to school and complete your degree and achieve the goals that we discussed.
I didn't know there was medication I can just take once a month. I mean, how come no one told me about this? No pills. I mean, I'm not too keen about injections, but Once a month doesn't sound too bad. But is there like a catch or something?
No, there's no catch, but as we did with the oral medications, let's talk about both the advantage and some of the minor disadvantages with the long-acting formulation. And we'll also need to discuss the treatment process overall.
Yeah, I understand. Like I said, I don't want to have to go back to the hospital, and I don't like taking pills to rule my life. The long acting medicine sounds like it's worth a try, and it would certainly make my parents happy. What more do I need to know to make a decision?
If you had a treatment strategy that saved lives, reduced costs, diminished family burden, and improved functional outcomes, in what proportion of your patients would you use it? That's not a rhetorical question because I'd really like you to step back and think about that. And also, if a loved one or close friend developed a chronic illness with the following characteristics: medication is effective in preventing relapse with an NNT of 3. Many patients with this illness do not take oral medicine as prescribed, and their physicians are unaware of it. The most frequent reason for relapse and hospitalization is inadequate adherence, and evidence suggests that relapses worsen outcome and prognosis. Now, that in fact is the case in schizophrenia. We know that medication is effective in preventing relapse with an NNT of 3. We know that many patients don't take their oral medicine as prescribed. We also know that the most frequent reason for relapse and hospitalization is inadequate adherence. And in addition, we know that relapse worsens outcome and prognosis. So in that situation, what would you do? Would you remind the person how important it is to take medicine as prescribed? Would you recommend adherence therapy and motivational interviewing? Would you send daily text reminders to take the medicine? Or would you ask if the medicine is available in a long-acting formulation? I think we're fortunate in psychiatry and in the treatment of schizophrenia to have available long-acting formulations. In many other areas of medicine, where chronic illnesses are also associated with problems in adherence, and as a result, an exacerbation or relapse of the underlying condition, our colleagues in those areas don't have access to long-acting formulation. So we really have an opportunity, but unfortunately, we're not taking full advantage of that opportunity. I think there are many reasons why long-acting formulations are not widely used, and particularly in early phase schizophrenia, because clinicians overestimate the degree of adherence. Sometimes they say they want to give the patient a chance to demonstrate non-adherence before they will implement a long-acting formulation. I think that's a mistake because, as we've said, the consequences of relapse are very significant even after 1 or 2 relapses early in the course of schizophrenia. The effect on that person's trajectory towards recovery can be serious. If you think about a young person who's had the onset of schizophrenia, wants to go back to school or back to work, hopefully they're able to after their first hospitalization. But what happens if they have another episode or a third episode? We can see some of life's opportunities being eroded very quickly. So I would say that the prevention of any relapse, if possible, is what we're aiming for. Other reasons we hear is that injections are overly invasive or punitive, that it's going to interfere with the therapeutic alliance. I think that's also a misperception. There's no reason why it should interfere with the therapeutic alliance. Some clinicians say, well, I'm telling my patient I don't trust him to take his medicine. Well, we have to explain that this is human nature. It occurs with any chronic illness. We want our patients to get the benefit of the medication that we've prescribed. Now, there are many studies looking at the effectiveness of long-acting formulations in comparison to oral antipsychotics. With Taishiro Kishimoto, we did an extensive literature review and meta-analysis of the cohort studies, and we looked at 42 cohort studies involving over 100,000 patients. And we showed that long-acting injectables were superior to oral medicines regarding hospitalization rate. And in fact, the patients receiving the long-acting injectable medicine as compared to oral medicine in these cohort studies were generally more ill and had been ill for a longer period of time. So the fact that LAIs were associated with a reduction in the rate of hospitalization was very impressive. There have been other studies, also naturalistic studies from Taiwan, looking at, in one case, 75,000 patients with schizophrenia, showing a significant reduction in hospitalization among those patients receiving long-acting formulations. And also in Taiwan, there was a study involving long-acting formulations in elderly patients with schizophrenia, demonstrating a lengthening in the time to rehospitalization amongst those patients receiving the long-acting formulation. So we know that there are a lot of important predictors of treatment outcome, the longer duration of untreated psychosis, along with poorer premorbid adjustment. We know that those patients who don't achieve remission within the first 3 months are at greater risk for poor treatment outcome. And when we think about time to rehospitalization, not using a long-acting injectable formulation increases the risk of hospitalization. Also, age at onset, duration of index hospitalization, the number of prior hospitalizations, et cetera. But the use of long-acting formulations is something that we can certainly help our patients get the advantage of. So the case of James, I think, is very illustrative of this dilemma. He was ambivalent about taking medicine. He took it for a while, but then he stopped. And as a result, he experienced another hospitalization. So there are tremendous quality of life implications of relapses. And I think he is an ideal candidate for a long-acting formulation because he wanted to go back to school. He was ambivalent about taking medicine. He stopped, he relapsed, and then he comes back to the hospital. We certainly should be considering the introduction of a long-acting formulation. And I think if it's done properly, we can have a shared decision-making discussion, and the patient is likely to agree to at least a trial of a long-acting formulation so that he can get the benefit of guaranteed medication. And we need to be able to have a conversation with our patients about transitioning from oral antipsychotics to long-acting injectable formulations. Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely goals. That is what I hope you will take from the CMEO briefcase to apply to your practice. Consider patients' goals and preferences and the role that long-acting injectables relative to oral therapies can play in achieving them. Utilize evidence-based strategies to engage patients in treatment decisions, and introduce long-acting injectables as an effective alternative to oral antipsychotics. Thank you for joining me today for Briefcase 2 of our 4-part CMEO Briefcase series on treatment hurdles in schizophrenia and bipolar disorder. To view additional briefcases on applying clinical updates to schizophrenia management, as well as tips, tools, and techniques to improve the detection of bipolar I disorder and strategies to communicate long-acting injectables as an effective treatment option for bipolar I, please visit www.cmeoutfitters.com. Thank you again for participating, and thank you for providing the best care for your patients.